Greetings to all. Most hip dislocations after a THR occur within the first 6 weeks following surgery. Only a small number dislocate for the first time several years after, and these are termed late dislocations. The most likely causes for late dislocations include implant wear, soft tissue destruction, and abductor disruption. However, many do not have identifiable risk factors. I would like to present Madam T, a 69-year-old lady who had a left THR 3 years ago for osteoarthritis. After the surgery, she was very happy and had a well-functioning hip. Unfortunately, she experienced 3 episodes of hip dislocation over a span of 6 months, and this had occurred while the hip was in an extended position or while extending when getting up from a chair of normal height. Otherwise, there was no back pain. In order to investigate the cause of her dislocations, we first assessed her component position. Upon study of her CT scans, we found that the cup abduction angle was 50 degrees, the cup anteversion angle was 18 degrees, and this places the cup within acceptable limits. Although the cup abduction was slightly open, but the hip had been functioning well for the last 3 years. We also ruled out infection, and after examination, we found the abductors to be competent. Upon assessment of the spine, we found that she had a grade 2 spondylolisthesis seen at the L4-L5 region with loss of lumbar lordosis. Interestingly, on MRI performed with the patient in supine position, this spondylolisthesis reduced and normal lumbar lordosis was restored. We also assessed her spinopelvic alignment, and these are the values obtained from that assessment. It is interesting to find that when she is standing, the functional anteversion was 38 degrees. To make sense of all these numbers, fortunately we have the hip spine classification, and these values places Madam T in type 2A category. So in summary, Madam T had a flat back or lumbar hypolordosis, a retrograde pelvis, and a mobile spine. Therefore, when she stands up, the cup faces forward, or it's in a position where there is more functional anteversion due to the retrograde pelvis. And in order to compensate for that, the hip has to hyperextend to remain upright and therefore causes the femur to impinge posteriorly, resulting in dislocation. We also call this stuck sitting. So in order to address her problems, we targeted both the hip and the spine in a single anesthesia. For the hip, we wanted to improve impingement-free motion and therefore, during surgery, remove the lipped liner and change it to an oblique liner, also known as a phase-changing liner. And this increases lateral offset and reduces the abduction angle. We also placed a longer head length to increase offset and used a larger head to increase jump distance. And intraoperatively, assessment of hip stability was good. This is a table showing the 4 categories of the hip spine classification and the inclination and anteversion targets. For the spine, our aims were to stabilize it and to correct the deformity, and therefore we performed a minimally invasive transforaminal interbody fusion at L4-L5 with percutaneous cement augmentation pedicle screws. And this is the check X-ray, and after surgery, the functional anteversion is improved to 25 degrees. Our patient Madam T recovered well, and 6 months on, there were no further dislocations. So much attention has been placed on spinopelvic alignment and its impact on THR lately. The association between the natural progression of spine disease and spinopelvic stiffness with late dislocation has also been reported. And in that study by Heckman et al., half of these dislocations were anterior, which is significant, as most prosthetic hips dislocate posteriorly. As we know, hip dislocations are multifactorial, therefore spinopelvic abnormalities were not the sole reason for the late dislocations in this study cohort. These patients were managed with revision surgery or conservative measures if they declined revision surgery. Interestingly, Yukizawa has found that not all patients with spinopelvic imbalance develop a dislocation. Out of the 62% of the 26 patients in their study cohort, only 1 patient developed a late dislocation. As spine disease presumably progresses with time, it may be intuitive to correct this problem as well. So although our patient was asymptomatic, we considered that it would be beneficial to correct the sagittal deformity in the spine, as it is the primary cause of the problem. Therefore, this begs the question, should prosthetic hip dislocation be considered a symptom of spine disease? We found another case in the literature where a hip dislocation was treated with sagittal correction of the spine. So in conclusion, it is important to evaluate spinopelvic alignment prior to THR. And in those patients who present with recurrent dislocations due to progression of spine disease, sagittal deformity correction of the spine should be considered. Thank you.